being recording. This is also my first virtual poster session. So is everyone seeing my poster here?
Yeah.
Okay, I see Eli giving me the thumbs up. So feel free to ask me to like zoom in to different parts of it or anything like that. But I'm going to go ahead and not read directly from it, but instead give a little bit more background about the thought process that went into starting this project in the first place. So we got, and by we I mean me and my advisor, Dr. Cepeda Benito, we got interested in the relation between stigma and smoking for a few reasons. One, that there is an emerging literature questioning maybe the difference between denormalization tactics and stigmatization, whether they are defined as different things and where those definitions overlap in the first place. And then also because the literature, or the quantitative literature at least, on the stigmatization of smoking has some really mixed results in that the stigmatization felt by smokers has some negative outcomes like concealment from their healthcare providers, concealment from their social circles, at times less engagement with cessation services, and then also at times impacts in their employment standing. But often there's also a lot of literature that suggests that the stigmatization of smoking has led to people attempting quitting more, being successful in quitting more, and even achieving long-term abstinence in some studies. So finding the kind of sweet spot of these denormalization practices without stigmatizing smokers became something of an interest to us. And that was compounded by an article, Thompson et al. 2007, that posited this idea of smoking islands, which is groups of already marginalized people, already subject to stigmatization from other sources that are also experiencing the stigmatization that comes along with smoking, and how stigmatization might differentially impact these populations that already have reduced access to healthcare and resources, and are maybe even interpreting the denormalization literature or denormalization messages differently. And one of those such populations could be smokers of rural areas. So you might all be familiar with Antonio's 2018 publication finding that the disparity between smoking rates in rural and urban smokers is growing, most starkly in rural women who don't seem to have a decreasing smoking rate at all. So that's where we started from. And to develop this, we used recommendations from Artino et al. 2014, about 5 of the 7 recommended steps. But it had first involved scouring the research both on stigma, denormalization, and then also the qualitative research about the stigmatization of smokers, getting the perspective of these smokers themselves. So you can see that in the middle here. I don't know if you guys can see my cursor, but we sourced 3 different types of literature to start developing our items. One was existing scales, and this was a direct recommendation from Artino et al. We identified 13 scales measuring stigma in related constructs, so including substance use, alcohol use, gambling, and obesity. There is one existing smoking scale, smoking stigmatization scale, that was adapted from the internalization of mental illness, internalization of stigma of mental illness scale. But the adaptation was pretty poor, and it has poor psychometrics. Then we also scoured the qualitative literature and the denormalization literature to extract these themes of stigmatization, coming up with 83 separate themes of how stigmatization can manifest in the lives of smokers. And the denormalization aspect of it we found critical because it seems like most of these existing scales did not really interrogate how policies that have been acted can perpetuate stigma. From there, we identified the themes, and you can see these themes in the middle. So things like alienation, powerlessness, ostracism. And then the three of us here at the top, me, my research assistant Kate, and Antonio, we independently came up with up to 3 items per theme. And I say up to 3 because our conceptualization of stigma is based on a 3-factor approach to stigma outlined by Boss et al. And that third set of yellow boxes highlights those 3 facets of stigma: enacted stigma, which is the actual negative treatment of the stigmatized group by stigmatizers; felt stigma, which is a lot of the psychological response and anticipation of that stigma felt by the stigmatized population, in this case, smokers; and then internalized stigma, which is actually the agreement with those messages. So not just being told smoking is, you know, something that is ugly or something you should be ashamed of, but actually agreeing with that. And so the next step in the process then, after developing all of these items, was to get together, have a consensus where we really interrogated the wording of them, the semantics, the meaning, everything like that, and whether or not we felt they fit into these categories of stigma. At that point, we resulted with 88 items, which we distributed to a lot of the experts at TCOR and in Vermont. A lot of you might have gotten this survey asking for feedback about the items we developed. And then some preliminary results, because this is still going to be subject to confirmatory factor analysis with smokers recruited through MTurk. But our preliminary results from our experts, if you guys recall, those who took it, we had a 4-item measure from 1 to 4 is whether it's inconceivable that this would be experienced by a smoker or incredibly likely this would be experienced by a smoker. Luckily, our experts agreed that most of our items were pretty likely to be experienced by a smoker. And then we had categorization with our facets of stigma. So again, that was internalized, enacted, or felt stigma. And we had over 50% agreement with our categorization. Based on this feedback and the fact that we had 88 items to begin with, we eliminated all items that had below a likelihood of 3. 3 was likely, so anything likely or very likely was included. And at that point, we had about 58 items. And so we used agreement with our categorization of stigma to further prune out some items until we got down to 45. And so that resulted in 45 items with an average likelihood of 3.34 out of 4, and agreement with our categorization of stigma at 60%. And so next steps from here is to actually subject this to confirmatory factor analysis. And then this is going to be part of a line of studies comparing the stigmatization of smokers by the public, by themselves, and then comparing that across cultures, and then also comparing it with internalized measures of stigma like an implicit association test. So that is my presentation. Does anybody have any questions?
Thanks, Tom. I think there might be time for one quick question here.
I'm sorry, I can't really see anybody's, like if they're raising their hand.
So if you have a question, you can just unmute yourself and go ahead and ask.
Tom, can you say a little bit more about your next steps? You overview, but how are you going to go about your next steps in developing this? You mentioned, is this, well, first question, is this a dissertation? It sounds like a huge undertaking.
This is a master's thesis. I appreciate you validating my feeling that it has been a huge undertaking. Luckily, it's also part of a line that will culminate in my dissertation. Yeah. So are you interested in knowing more about the development and validation of it, or where that line of research goes?
The development and validation.
Okay. So it's included in a large survey along with some scales that will hopefully give us some sense of convergent validity and divergent validity, including scales of nicotine dependence, reasons for quitting, and then Kessler's psychological distress scale. All of this will be rolled out through Amazon's MTurk to recruit smokers. I'm not sure if you're familiar,
I am.
which we've taken steps to ensure that people aren't using VPNs or international participants aren't involved in this. And we've looked at the research, and it seems to be a representative source of recruitment. And then from there, it's going to be subject to confirmatory factor analysis. So we're going to impose the model of enacted, felt, and internalized stigma on the data and see how well the data fits to that model.
Okay, thank you.
Thanks a lot, Tom. That was a great presentation. You can go ahead and stop sharing your screen. And next up, we have Carolyn Evemy from the University of Vermont, who is also a PhD student here at UVM.
Okay, is that working?
We can't see your screen.
Oh.
Now we got it.
Okay.
Thanks.
Okay. So, yeah, my name is Carolyn Evemy, in case you haven't heard. And yeah, I'm a second year experimental student working in the Vermont Center on Behavior and Health. So this study explored individual differences in nicotine dependence, smoking characteristics, sociodemographics, and behavioral economic measures of cigarette demand among a national sample of pregnant women as a function of urban versus rural status. So my last year of work kind of put me in the direction of looking at behavioral economic measures of the reinforcing value of cigarettes in pregnant populations. And recently I proposed that using a behavioral economic measure over like a demographic or smoking characteristics can elucidate important targets for interventions by giving us more modifiable characteristics to work with. So the basic idea here is that we wanted to see whether these behavioral economic measures were consistent across urban and rural residency. And then we wanted to compare the potential associations to more conventional sociodemographic, nicotine dependence, and smoking characteristic variables. So just a little bit about the methods. The data were taken from an intake survey that the women took, 401, took in an attempt to enroll in the COBRA remote smartphone-based smoking cessation trial using financial incentives. And all the participants were pregnant at the time that they took the intake survey, and they were also active smokers. So when you look at the results, I guess the first thing you see is that almost every sociodemographic variable was associated with urban-rural status, with one major exception of education. But we did somewhat anticipate that, as you can see, we inadvertently recruited a sample with like about 90% in both urban and rural groups having 12 or more years of education, which was pretty unexpected in the national sample. Then we looked at smoking characteristics and measures of nicotine dependence, and we saw that some, but not all, were associated with urban-rural status. For instance, we saw that rural women were smoking significantly more cigarettes per day before they were pregnant, but then, once they were pregnant, that kind of evened out between the two groups. We also saw time to first cigarette after waking was pretty even across urban and rural populations, participants as well, which again was not a huge surprise. I think several studies, and one in particular that comes to mind, has indicated that across tons of measures of nicotine dependence, the time to first cigarette is the strongest single item predictor of quitting success. When we looked at behavioral economic measures, we saw that none of our variables were associated with urban-rural status. And we wanted to take all of this one step further, so we put all the variables that were significant in these bivariate analyses into a backwards elimination stepwise regression model, and saw that the rural dwelling women, oh, and that's in the top right, and we saw that the rural dwelling women relative to the urban were more likely to be older and married, and they were less likely to consume menthol cigarettes or have their usual brand be menthol. So overall, these results were very promising to us. They indicated that measures of nicotine dependence and behavioral economic measures of demand were pretty consistent among groups, and gave us an idea of how targeted treatments incorporating these modifiable characteristics that you would derive from these measures would be able to translate across subpopulations of pregnant women specific to urban and rural populations. And I also just want to mention that, I kind of flew through this, but I just want to mention that we are also very interested in looking at urban rural status as a function of the smoking characteristic and behavioral economic measures, but it would have been a very cluttered poster, so we stuck to this. And I think that's about all I have on it. So
Thanks, Carolyn.
Yeah.
We have time for some questions if anyone has any questions.
I do have a question, Carolyn. Nice poster. I was wondering how urban rural was defined.
yeah, so we used FIP codes, which are they're similar to zip codes, but basically in the intake survey they give a zip code, and then we used those zip codes to determine whether they were in a metropolitan area or not, and that was based off of I believe it was like 10,000 or more in their county was urban, and then less was rural. And we counted, they did measures of, the way that they do it was rural and then somewhat urban or somewhat metropolitan and then completely metropolitan. And we just counted somewhat and rural as rural.
Okay, but so suburban would be in there somewhere in the range.
Yeah, I think they would have put that into the somewhat metropolitan area. So the surrounding suburban populations would be lumped into the rural.
Yeah.
It definitely depended on the vicinity, though.
What do you mean?
For instance, if they were within driving distance of the city, they may have been included. It depended on where the county lines were drawn.
Okay. I'm asking because I know there's a few, at least a handful of ways to define rural. And I know I've looked into this a little bit with the alcohol literature, and it's not cut and dried. There's, suburban, you see, like, you want to say, well, urban and rural are both lower than suburban. And, it's just kind of, there's definitely not a linear relationship. And so when you make just a split into two groups, there may be more going on there, is what my thought is, if you were able to more closely refine the measurement of rurality.
Yeah.
Absolutely. I totally agree. There would have been, that's something that we can definitely go back and spend more time on. I think it would have been one difficult time we had with parsing these out was that there was also like a very limited amount of any kind of databases that were up to date. So we actually ended up using a database from 2013, which was the most recent one that they had.
Carolyn, do you mean by database for the zip codes, or what do you mean by database?
It's an Excel sheet, but it's a list of Federal Information Processing Standards, or FIP codes, which is, it's like, it's
Okay.
different than a zip code.
Okay, that's fine. That's fine. One thought that I had was we have done in the VCBH, we've published several papers. The prior poster mentioned one of them with Antonio, and then Tyler Nyber and I did one on rural women, and probably closer to this, rural versus more urban women, and of reproductive age. We're interested in whether there were differences in the likelihood of pregnant women from rural areas quitting smoking versus urban. And, well, that's what we found, that there is, and we were interested in going into that. But the reason I mention it is, so it's Tyler Nyber and it's Ploswan, and but the definitions of how we were using census definitions, but it might be helpful if you haven't seen them.
Yeah, absolutely. I've seen it, but I can definitely go back and read those
Oh,
methods.
you have seen it. Okay.
We got this from the Census Bureau, so in it, I think it came from TCORS, so it may be the same. We may have the same methods here.
But what caught my attention, if I heard your right answer in Gail, it sounded like you said you were collapsing suburban with rural. And that just got my attention. So I don't know, you might play around with it a little bit because it could make a big difference.
Yeah, I think it's, especially as the suburban communities continue to become more city-like, it's definitely something we could spend more time defining.
You've heard in talks today about, socioeconomic status, opportunity, job opportunities, tobacco control, tobacco regulatory enforcement. Those things vary, and I would guess suburbs are going to be more like the metropolitan area and not like the rural areas. But
yeah, I think a lot of them were, because we did end up having quite a split between, well, we had 213 in the urban. So I wouldn't be surprised if a lot of those more like suburban areas had been lumped into the rural category, which we only had 63 of.
Well, thanks, Carolyn. That was a great presentation. I'm going to keep us moving along here. Next up, we have Rhianna Wiley, who is also a PhD student at the University of Vermont. So Carolyn, you can go ahead and stop sharing your screen, and then Rhiannon can share hers.
Yeah. Hey everyone, can you see my screen?
Yeah.
Okay, cool. So thank you, Eli. So as Eli said, I'm Rhiannon Wiley. I am a doctoral student here at the Vermont Center on Behavior and Health. And today I'll be presenting to you some research that my team has been looking at, examining how individuals from vulnerable populations have been responding to the COVID-19 pandemic with regard to their smoking behavior. So kind of drawing back to the theme of this conference is obviously rural health and addiction. And one thing that we know about rurality is that it is a risk factor for cigarette smoking. Drawing that back in with COVID, I don't have to explain to you how much COVID has changed our lives in terms of, all the quarantines and people social distancing and wearing masks, and obviously like the public health measures that have been taking place have really changed so many aspects of our lives. And one question that some of my colleagues and I were wondering was, how was this impacting individuals who smoke, but particularly individuals that we have studied in the past, who are from vulnerable populations? And another aspect of that question is, how does that differ for individuals who live in urban areas versus rural areas, given that, especially early on in the pandemic, there was more concentration of the pandemic in urban areas like New York City, and now as the situation has developed, you're starting to see more like disease transmission in rural areas. And on top of that, there are obviously differences in healthcare access and things like that with the urban and rural split. So in order to get at this question, we contacted individuals that had previously participated in one of the trials that we conducted here at UVM that was investigating the effects of very low nicotine content cigarettes among 3 vulnerable populations. And just to mention briefly, those vulnerable populations are women who are socioeconomically disadvantaged, individuals who are opioid dependent, and people with affective disorders. And over the course of this summer, we contacted them, invited them to participate in an online survey where we asked them a lot about their perception of the COVID-19 pandemic, as well as their current smoking behaviors and smoking related behaviors in the context of the ongoing pandemic. So of the 457 individuals that could have participated, we had a just under 50% response rate, which was a lot higher than any of us had anticipated, given that it had been, for some of these folks, like the last time we had contacted them for study participation was like 3 years ago. So we had a pretty pleasing response rate. And we categorize these individuals as urban or rural residents based off of their zip codes and home address information using methodology from the Federal Office of Rural Health Policy. Can go into that more in the questions if anybody wants to know more about that. And we then compared urban and rural respondents on a couple measures of their baseline demographics and smoking characteristics, as well as their responses to a couple survey items that are related to smoking behavior. So over here on the results table, you can see that largely the urban and rural respondents didn't differ very much in terms of their baseline demographics or smoking characteristics, except that there was a higher proportion of menthol smokers in our rural group. Another interesting finding was that all of these individuals, when they had participated in our study, they were smoking cigarettes. When we recontacted them for this survey, about 20% of individuals across this entire sample had indicated they had quit smoking since their participation in our study, but there did not seem to be a difference by urban or rural status. Among the individuals who indicated that they had quit smoking, the vast majority indicated that they had quit smoking before the COVID-19 pandemic, so it wasn't in response to the coronavirus, but that did not differ by urban or rural residents. That is very hard to say. We also asked our participants a couple questions about if, in response to the COVID-19 pandemic, they had changed aspects of the way that they procured their cigarettes or smoked in order to prevent themselves from contracting COVID-19. So you'll see some of the items here on that table. Largely urban and rural individuals didn't really differ on these items, but there were 3 items in which they did differ. So urban residents were more likely to say that they were still leaving their house specifically to buy cigarettes, but rural residents said that they were more likely to be buying cigarettes from an Indian reservation. And when it came to how people were being conscious of how they were touching their face when they were smoking, people who were living in urban areas said were more likely to say that they were changing the way they smoked to kind of prevent that contact. So overall, it looks like there were not too many differences in terms of how urban and rural respondents were changing their smoking behavior during COVID-19, except for that some kind of interesting differences that regarding that buying cigarettes from an Indian reservation and some individuals who are more likely to continue leaving their house just to buy cigarettes, even though, it's COVID times. You don't want to leave your house too much if you don't have to reduce your likelihood of getting the coronavirus from some stranger on the street. And this is very interesting that we had more menthol smokers in our rural sample. And this is kind of in contrast with previous research that indicates that there's a similar level of menthol smoking between urban and rural residents in the Northeast of the United States. So that was very interesting. Haven't really figured out why that is in our sample here. And one kind of future implication. So this study, these participants were all individuals who completed this study, the prior trial at the University of Vermont. So they're largely residents of the Vermont and just across the lake in New York area. And Vermont has largely been spared from the worst effects of the coronavirus pandemic. So it's interesting that we didn't see a lot of differences in how people were responding to the COVID-19 pandemic, but I wonder also if that might be just an effect of the fact that we've been kind of sheltered and in a bubble. And it'd be really interesting to see if our sister sites that are also using this survey see any differences in other states. All right.
Thanks, Rhiannon. We have about 2 minutes for questions. I can start us off. I guess this is, well, I have one clarifying question and one comment. I just think it's striking to notice that less than 10% in your table 2, less than 10% in both urban and rural reduced their cigarette smoking as a result of a deadly pandemic. I mean, that says something about cigarette smoking and addiction. And then a clarifying question, the leaving your home house to buy cigarettes, did you have any pre-pandemic data on that? Like, is there any suggestion that the 50 versus 65% or 67.5%, has that changed at all because of COVID-19?
Unfortunately, I have no pre-COVID data for that. We did ask, the stem of this question was, since the coronavirus pandemic, are you doing these things? But obviously we don't have any prior data on this. So kind of what you see is what you got.
Rhiannon, it crosses my mind that I recall a paper by Nate Dugan out of the T-Core series. I think I may be a co-author on it. I can't remember for sure. We did a series of these papers, but I think I remember him identifying differences in purchasing practices among rural and urban participants. So it may be, a source of data along the lines that Eli was talking about. I think I remember the rural people buying like larger quantities so they didn't have to travel. I don't think I'm an author. I am an author with him on this rural urban stuff, but I don't think it's one of our papers. I think it might be in others, but if you look at, it's Nathan Dugan from Ohio State University.
Yes, reference number 5. Oops, sorry.
Okay.
Well, that's not the paper, but I know you published with him. Yeah.
Okay, so you'll see something in one of his papers about that. And my guess is the title of the paper will give you a heads up.
Okay. All right, thank you. I will look into that.
I just wanted to add to what Eli said about how the less than 10% is so indicative of, the nature of smoking and its addictive potential. But I also think it's indicative of the way the country has handled the pandemic. I know a few months ago, there was articles about like 1 million smokers in the UK had quit during the pandemic, but it doesn't seem like it's been framed that way here, like an opportunity to actually quit. Or that sometimes people are even downplaying the seriousness of the pandemic entirely.
It's a good point. I think, Tom, we could always be doing better. There are some data in Vermont that there has been a big increase in quit line usage since the pandemic started, but it can always get better.
Yeah, and this seems to also tie in with one of the earlier presentations from today that was indicating how substance use seems to have increased in, just like substance use generally has increased in the wake of the coronavirus pandemic. People are just not doing very well. And they're also bored.
And these are smokers selected because they're from vulnerable populations that are probably less likely to quit or change or reduce.
Well, thanks, Rhiannon, for that presentation. I will move us along to our final presenter, Emily Pomichter, who is also a PhD student here at the University of Vermont.
Emily, you're muted.
Thank you so much. Sorry. So my study was looking at the role that expectancies play in mediating the relationship between weight concern and negative affect and nicotine dependence in both smokers and vapers. So this question was based on some prior research showing that fear of gaining weight and depressive and anxious symptoms are both perceived barriers to quitting and risk factors associated with smoking. In addition, there have been some recent findings suggesting that these relationships may generalize to vaping as well. So the first hypothesis was that the relationship between the fear or concerns about gaining weight and nicotine dependence is mediated by the expectancy that smoking or vaping can be used to control body weight and appetite. So the hypothesis is that individuals with high concerns about their body weight are likely to hold greater expectancies that nicotine ingestion can lead to more body weight control, and then that in turn leads to more nicotine consumption and dependence. And then the second hypothesis is that the relationship between depression and anxiety with nicotine dependence is mediated by the expectancy that smoking or vaping can be used to reduce negative affective states. So individuals who report greater symptoms of depression and anxiety are more likely to hold greater expectancies that nicotine will help them to feel less depressed or anxious, in turn leading to more nicotine consumption and dependence. So I recruited participants using Amazon's Mechanical Turk to complete a Qualtrics survey with a number of questionnaires, including, and so those are down here, all of them are here, but of particular interest to this study are the Goldfarb Fear of Fat Scale, the Depression and Anxiety subscales of the Symptom Checklist 90 Revised, the Penn State Cigarette or E-Cigarette Dependence Index, and the Smoking or Vaping Consequences Questionnaire. We had about 3,000 MTurk workers complete our screening survey, and from those 3,000, we recruited 531 smokers and 421 vapers. And to test our 4 mediational models, which you can see in the middle here, if I zoom out a little, you can see the whole thing. We used Hayes's process macro for SPSS. And so our findings ended up supporting both models in both samples. Weight control expectancies fully mediated the relationship between fear of fat and nicotine dependence in both vapers and smokers. And negative affect reduction expectancies fully mediated the relationship between depressive and anxious symptoms and nicotine dependence in smokers, but only partially mediated the relationship in vapers. The variance in nicotine dependence explained by all of the models was modest. However, both models predicted more nicotine dependence variance in vapers than in smokers. So the weight control model explained about 2% of the variance in nicotine dependence amongst smokers, but about 9% amongst vapers. And the negative affect reduction model explained only 2% of the variance in nicotine dependence amongst smokers, but explained 15% of the variance amongst vapers. So these findings provide some insight into the process underlying the relationship between weight concern and negative affect and nicotine dependence. They also add to a pretty limited literature on vaping motivations and expectancies, but suggest that, in fact, these models may be more important for predicting e-cigarette than traditional cigarette dependence. And most importantly, they suggest that individual psychological factors may indirectly become drug use factors, in particular nicotine use factors, by increasing a person's affinity to adopt drug use expectancies that are relevant to them. Of note, it is important that these were all point collected, and so you would need longitudinal data to examine the causal relationships, but it does provide some preliminary evidence of those relationships.
Thanks. It was a great presentation. We have about 3 minutes here before the end of our session for questions for Emily.
Hey, Emily. So just to clarify, so these data were with a mixed gender sample, is that right?
Yeah, it was a mixed gender sample. I can actually zoom in on some of the demographics here. We actually had to collect in 2 waves. We didn't get enough women in the first wave, so we collected a women-only wave afterwards, but our sample ended up with 43% women in the smoker group and 51% in the vapor group.
Yeah, I was wondering if you could speak to, I don't know if you've done these analyses, but whether or not there might be a moderating effect of gender or perhaps of age on these effects that you're seeing.
Yeah, so I haven't run those analyses yet. We did have some kind of interesting findings, if I can sort of scroll over here, maybe. I don't know if you can see over here. The men actually had higher levels of weight concern, or not weight concern, in this case it's fear of fat and body image inflexibility than the women. So we're planning to do some analyses on that because it's a pretty unusual finding to see. But we will be doing some analysis on whether there's a difference by gender as well.
Great, thank you.
I'd be curious to know how duration of smoking or vaping moderates these relationships as well, because I could see addiction being perpetuated in its early stages by these expectancies, but in its late stages by just the reinforcing mechanisms of addiction themselves.
Yeah, and we do have data on the how long people have been engaging in these behaviors. So it is possible that the length of time can account for some of the difference in vapors because people may have been smoking for significantly longer times than vaping.
Just to add to that comment, Tom's, I wonder if you have data, if it would be possible to see when the onset of fear of fatness was, if you can measure that, but then maybe more specifically when the onset of cigarette dependence was, to see if you can get temporal order for that mediation analysis.
Yeah, unfortunately we don't have data on the fear of fatness onset. I think that would be a little bit challenging. I'm not sure if there's a standard way to get that other than longitudinal data collection, but we can look at the onset of cigarette dependence. And I did create a brief questionnaire as to the extent to which people believe that they are smoking to reduce food cravings as well. So we're going to be looking at those data after we look at the validation of that novel questionnaire.
Well, great. Thank you, Emily, for that presentation. And thanks to all the presenters. Those were great posters, and it was good to see everyone, and nice questions, great conversation.
Yeah, yeah.
Thanks, everybody.
See you tomorrow for the rest of the conference.
Good to see y'all.
Bye-bye.